Hi everybody, this is Sepalika's live on bioidentical hormones. I'm Mahesh Jayaraman, co-founder of Sepalika.com. We're a women's online hormone health clinic. Today's topic is especially focused on bioidentical hormone replacement therapy for fertility, so for infertility in particular. So I'm going to bring on our guest board. There he is, Dr. Vivek Kadambi.
Hi there.
Fantastic. So let me give everybody a quick intro about you, Dr. Kadambi. Dr. Kadambi is a very senior doctor. He is, of course, an MBBS. He is gold medalist from the University of Pune from his early days. Of course, those are, as far as doctor is concerned, the old nostalgia days. He's got decades of experience behind him now. He was awarded the fellowship in endocrinology in the year 2009, and he has done his fellowship in BHRT and longevity medicine from Fort Wayne Endocrinology in the USA. In 2015, Dr. Kadambi has obtained the Advanced Bio-identical Hormone Replacement Therapy Certificate in Training from the Academy of World Medical USA. And you know, it's such a pleasure to have Dr. Kadambi with us. Today's topic, of course, we are focusing on the use of bioidentical hormones in the field of fertility medicine. If anybody is having trouble conceiving, any issues with the reproductive system, how can we use bioidentical hormones to help with that? So my first question to you would be, what are bioidentical hormones?
All right. So thank you, Mahesh. And indeed, whenever I get an introduction like that, it's not nostalgic because it looks like many years ago. Anyway, so a very important aspect, and I will say right from the start, it's very interesting that bioidentical hormone replacement therapy, basically it has evolved from something which was very well known called HRT, hormone replacement therapy. Now, the prefix bioidentical completely changed the entire outlook of HRT, and this is very important to understand because a lot of people assume that any hormone replacement therapy, any HRT, is there's hardly any difference in BHRT. What's the big deal about bioidentical when it's I use really splitting hairs? And as you know, if I'm known to split hairs because there's one of the reasons why I don't have any hair on my head. So just remember this, that these questions often do come. So let us look at it this way that. I'll take it through the history so you understand. The term HRT was very commonly known, and sometimes terminology changes for different reasons, not necessarily for scientific reasons. So hormone replacement therapy, fine. What does that mean? That means that we talked about somebody who was in menopause, okay? Women that needed, very simple, women need estrogens, okay? Men are from Mars, women are from Venus. So women need a replacement of estrogens, and men need testosterone, replace testosterone. And in fact, they did not even apply replacement of testosterone to the term HRT. Hormone replacement therapy classically applied to replacing women in menopausal women and using some kind of hormone replacement. But if you look at it in the sense of the word, even a thyroid treatment is a replacement of the thyroid that your body is not producing. Even if somebody says that I'm taking insulin for my diabetes, it's a replacement, and these are all hormones. So, but classically, the word HRT was applied to women where the hormones had to be replaced because in menopause, they realize that if you don't replace it, they get osteoporosis, they get heart disease, they get many conditions as a result of not having their hormones, and their lifestyle and their life expectancy comes down. Unfortunately, the hormones that were used were really not hormones, they were chemicals. And they were, to give you an example, if progesterone is a hormone, progesterone, and you give medroxyprogesterone acetate, you just use the word progesterone and change the molecule, and you expect that I'm going to give this as a replacement of progesterone and the body is going to be very happy and accept it. That's not true, because the body, it will have some actions of progesterone, like control the bleed maybe, but it will actually work quite the opposite and actually cause more harm. So among many studies, there was a very wide study called the WHI study, and that study actually sort of concluded, though it was wrong, but the net conclusion was HRT is bad, it's dangerous, stop HRT, don't replace hormones. But that was a wrong conclusion because the study itself was not as bad, but as you know, people like to pick on the negatives and highlight the negatives. So what should have been the conclusion is chemical or non-bioidentical artificial HRT can have side effects, because remember, it's the same hormone you use for birth control. So it's not, there's not any different. So if you look into a very technical way, the molecular structure, I won't go into that. Remember, even if you change a position of a molecule, let's say even the thyroid, just the position, not even the molecular formula, the properties change. So it's very, very important to be clear that biosimilar, raise the red flag. Biosimilar, similar is not means the same. It's like, you go for a Nike shirt and then somebody gives you a knockoff and the tick is on the reverse side. It's similar, so it's as good. So we're very, very particular about branding when it comes to clothes, when it comes to golf clubs. So we should be equally clear about what we put into our body. So that is the word bioidentical came in. And once bioidentical came in, the entire outlook changed. What was considered dangerous actually became very useful, very positive. But however, that had to go back to what is called as compounding pharmacies. So the compounding pharmacies had to make this, because you could not get bioidentical hormones from the retail shops. It's not that they were not making them, but there was no money in them, because you can't patent natural products. So there was no money. So gradually it went, many of these people stopped. And therefore, compounding and bioidentical hormones went hand in hand. You cannot think of bioidentical hormone replacement therapy without compounding. And with compounding, a large part is bioidentical hormones. And then they extended it. It's not just estrogens, not just the progesterones, add testosterone, the DHEA, thyroids, all the other hormones that started coming into the picture. So when you look at the definition of bioidentical hormones, it has to be identical. You use hormones as nature has given it. That's one rule. And the second rule, which is equally important, is your bioidentical hormone therapy is incomplete if you do not do what, say, Mahesh is doing, the nutraceuticals, building the foundations. So I could, of course, go on and on, but I hope I've explained this important concept of bioidentical. I don't like the word biosimilar.
Yeah, right. Yeah, absolutely, Doc. Clearly, somebody like you who's spent such a large sort of a period of time studying this, you could continue with it in great depth. But if I can sort of summarize for some of the audience who may not be very familiar with right. some of these, the important thing you have said is it needs to be exactly like the body makes it. So it's bioidentical, not biosimilar. Exact molecular structure delivers fantastic results in the right place. That is number one. Number two, and very important, which you've highlighted, most of us are familiar with women who take thyroid medicine. So quote unquote, it's called thyroid medicine. Nobody gives the term thyroid hormone. So the doctor never tells you he's already giving you a hormone. But the truth is that that particular thyroid medicine is actually nothing but a hormone. But sadly, it is a poor form of the hormone, not bioidentical. Can you speak a little bit about the thyroid medicines that are used in this country, and maybe through that example, people can understand better?
Very good. I think the thyroid is a very good example, but I'll just end the last question. When you say bioidentical, there are two more things that come with it. And in that two more addition, which is very important, is just because something is bioidentical, but if you use the wrong route. So the route of administration also becomes important. Like, if you're using skin creams, sublingual versus oral, because many of the hormones are not thyroids, can be taken orally, but many hormones is unnatural to take orally. It has to go directly into systemic. So bioidentical route of administration also important, and the physiological dose is also important. So if you use anything in excess, that's again going against nature. So bioidentical has those rules. Now come to the thyroids. Now thyroid should be called thyroid replacement therapy, but I believe that once people realize that thyroid is a hormone, that's first thing is people should accept that thyroid is a hormone, and this hormone is not a bad word. Hormone is not a scary word. I need replacement of thyroid. Why? Because my body is producing thyroids, but it's not able to function or do the job it's supposed to do. Why is that? There can be many reasons, but to make it easier, you must understand there are two types of thyroid the body produces. Well, mainly two types. One is called the T3, another is called a T4. And why is 4 means it has 4 of these. Each molecule have four atoms of the iodine, and in 3 there are 3. therefore, by removing one of those iodine, I would say atoms, it would become T3, which is the active form. So usually what is available, especially in India and most countries, is something called as T4 or levothyroxine. Why? Because one, it's produced in bulk. Two, it's very inexpensive, very cheap. And three, it does work in many cases. So I'm not saying it will not work. Because the body will convert that T4 into T3.
Not to interrupt, Doc, but I think a lot of people may know it by the name that they buy it. So this is Thyronome or Eltroxin.
Yes.
For all the viewers who are listening. That's the brand name. I mean, that's the generic molecule. We all know about thyroid medicine. Please continue.
Yeah, thyroid. No, please interrupt me at any point of time. Do not wait for me to, do not wait for me to catch my breath, because it's very difficult to do that. So coming to the Thyronome, Thyrox, Eltroxin, in abroad Synthroid, whatever it is basically levothyroxine. So therefore, there are many technical issues with that. I'm not saying it doesn't work. It works, but remember, it doesn't work to the level that you expect it to. Therefore, we need to give the body the T3, and sometimes in a proportion, T3, T4 in a combination. Why? Because finally it is a T3 that's doing the job. So to cut a long story short, when you are young or your rest of your body is very fit, the T4 very efficiently gets converted to T3 and you have no problem, and that's a very cost effective, works very well. Then comes, in most cases, what happens is it works as a, I would say, very mediocre sort of it's never perfect, never satisfying, because it doesn't convert into T3. And how do we know that? When you do the blood test and we check the free T3 levels, actually check the levels of T3, we find that it's not up to the mark, although the TSH, what is the classical parameter that is taken, thyroid stimulating hormone, which is well within the range. So labs are showing is well within the range, but the patient is not happy. Particularly when it comes to infertility. I'm trying to bring it to infertility. Infertility and some conditions where the need for T3 is that it's not just enough to have, it needs to have very good optimal amount of T3, because ovulation is a higher function. Whenever in the body you have a higher function, the body needs something which is more pure or of better quality or better potency. So while it may work for those who are looking at energy levels, maybe sleep, maybe weight, etc., when it comes to fertility, the body is very fastidious. It wants perfection, and I'm not saying that you can't. Even if you conceive, you might miscarry. Why? Because the body knows that this T3, which is so important for every cell. There are some of the hormones, they work at every cell at the mitochondrial level. So they are required in optimal quantities. This is a second thing that you need to understand. It's not enough to have, like you can say, I eat enough food. But question is, are you eating optimally and are you getting the good quality of food? We all understand that. So therefore, it is important, particularly in the topic of infertility. So now that I've explained the differences, and I can tell you there are many, many reasons. If you look at the reasons why your body doesn't produce T3, I myself look at it and say, look, out of the 15, 5 of the reasons I have myself. So I'm sure if I were to take thyroid, I would not convert it efficiently. And therefore, I'm looking for something more efficient. And when it comes to infertility or management of pregnancy, the body needs even better, doesn't want junk. And hence the role of T3 in management of infertility is extremely important. And you can do it in many ways. Mahesh is able to endogenously build, which is 5-petal program. You have your 5-petal programs, and you might increase the body's T3. But after some level, you might need that little bit addition. So I don't know if Mahesh is 5 petals. Am I the 6th petal, or am I the bee, or am I the pollen, or how do I use that same metaphor that sometimes the petals are not enough. The petals itself may be important to attract the bees and cause the pollination, but you may need something more. So I am either the extra petal or whatever name Mahesh thinks he can give me. That's in respect to T3. So anything further on that?
I think you've really set the agenda, especially for fertility. I think it's a beautiful way to enter into this topic as well. Just continuing with the thyroid, we often find that people come with so-called quote-unquote normal printed lab ranges in their report. So many times when we look at a basic lab report at Sepalika, we will tell patients, your thyroid is okay, but it's not optimal. It's not at that perfection that is required for fertility. Can you speak a little bit to the kind of ranges that are printed in Indian lab reports and what you
Yeah,
see
okay.
compared to the West and especially functional medicine?
Yeah, I think this is a very vital part, and even for laymen, it's important to understand. One thing I have learned that when a couple comes with a fertility issue, okay, they are more educated than the doctors around. I'm not saying this in a negative sense. Of course, they have Google, they have a lot of information. So you know for a fact that I'm presuming also that our audience over here would have a little bit more knowledge than an average individual. So taking that as a cue, when your question was that what was the question again? Sorry.
What is the, I mean, should we
Yeah,
accept
range.
the
Yeah.
normalcy printed ranges?
Yeah. So this is one very important part that unfortunately, though we have been taught in medical school that labs should only be taken as guidelines, as supportive. You must treat the patient clinically. You must use your judgment. You must use your clinical acumen. Believe me, as you get into, you come out of the medical school and colleges, you get into protocols that ultimately say what's a lab test, what is the value, and you start treating lab tests. Okay, I'm not saying it's wrong. In many places in the hospital, it has this value. But when you're looking at subtle functions or higher functions, I'm talking infertility or even otherwise lifestyle functions, you should know the limitations of the lab. So let me tell you the limitations of the lab, and then you will be able to draw conclusions. For example, if I were to just do a TSH, some people don't do the entire thyroid. There are two types of thyroid, T3, T4, TSH. So some people do, okay, TSH is enough because the lower the TSH, the higher the thyroid. The higher the TSH, the less thyroid we have to give you. So it's a very simple way for most of the general practice to say, okay, let me keep your TSH in one range. If the lab says 0.5 to 5.5, I will keep it around 1.5 or 2, and I'm okay because that is okay and I'm safe. So that's one of the ways, but that may not be enough. Why? Because one, if you look at the TSH, even you read the lab, you will see one small print that says subject this TSH can vary as much as 50%. Okay, there can be a diurnal variation of 50%. So if you say 50%, that means if TSH is 2, it can be 4, it can be 1. So that's a big range. So a 50% is not a small thing, and if that is going to affect your, if that is going to be the criteria. Second, you will always see in many of the reports that please correlate with clinical findings. Okay. So as far as the lab goes, lab is going to give you a value, it's going to throw out a value, blood value, and many things have been continued because for changes to happen in medical science, unlike IT, where you can change very fast, it's not that we all have the knowledge. We know in our blood test, we should depend less and less on the blood test. We need to look at a better tests which are based on muscular dynamics, etc. But you see, there's something called as insurance companies. There's something called as of the medical school, or they will say to change that is a long process. So even though the advancement happens in medical practice, it takes a long time before it trickles into the overall general practice. But there will always be a set of practitioners, let's say the top 5 percentile, who will be the progressive ones, who will understand, who will do it. And that's how the system of medicine is. Whereas medical equipment is not a problem. New equipment comes immediately, very fast. FDA approval, and you go to super equipment. That's one part. So that's second. If you are doing a lab test and you're doing only TSH, and there are some cases where maybe the TSH is low because pituitary is not producing enough. So there's a problem there. So sometimes it can't distinguish between where the origin of the disease or what the root problem is. And it takes into consideration that 80% are because of thyroid problems. So let's treat the thyroid. You could go wrong there. And lastly, even if you were to check the T3 and T4, many people check maybe because of cost, it's cheaper. They do the total T3 and total T4. Again, that gives you half the information. So sometimes I feel that I'd rather not have the information. If somebody comes with a test which is not complete and which is not making sense, I say, look, how about this? Let me not look at the test. Let me talk to you. Tell me how you feel. Let me clinically assess you. And then I'm better off treating you through the clinical than if I go for a test which is been done, which is not the test I want, or which is half. So half truths are more dangerous than the lies, because sometimes lies you can tell very easily. This is exactly what you need to apply here. So to answer the question about lab tests, yeah. Go ahead.
Yeah, sorry. We've got one of our doctors responding and, agreeing with you, saying that standard treatment guidelines in healthcare usually lag behind by 5 to 10 years to be
5 to 10 years.
created and to be approved for general use. So obviously, when you look at a lab report, or Sepalika, who's functional medicine, looks at a lab report, we look at free T3, free T4, we say free T3 of 3.5, we say free T4 of around 1.5. These guidelines aren't there yet. And this can mean the difference between fertility and infertility for some couples.
Yes.
Can you speak a little
believe
bit?
Me, yeah, and believe me, sometimes it's not that expensive also, the difference. If somebody says, you know what, your free T3, it is costing me 100% more. If it is costing 200 rupees and I'm charging you 400, if it's 400 rupees, it's not a big difference, absolute. So you can always say, oh, it's expensive. But actually, if you look at the absolute cost, it's not that much. So sometimes I feel confused when a person says it's expensive, and the cost is, maybe a few hundred rupees or even a few thousand rupees. It's not that it's going into tens of thousands of rupees. So that's
Sure.
fine. But when it comes to infertility, I think at least one thing is clear. People want what's best for them. And you can explain to them value. It's different between cost and then different between the value of a particular test. All right.
When we look at infertility, what's the speed of results? Can you speak a little to the kind of results we have seen?
I think the last 1 year has been a real eye-opener to me, thanks to Mahesh, because our association has been quite recent. But see, the association, when you had, because of when you have a common patient you're treating, somehow creates a bond between two practitioners, because we are all looking at the welfare of that one patient. I know individually also we do. So typically when someone would come for management of or improving their, let's say, ovulation. So let's say that if they ovulate, that's the first sign of that fertility. Then of course we look at the conception, and then we look at whether the tubes are patent or there's some reason why there's an obstruction. So all those things usually are done, and that thing you don't have to worry, because most gynecologists do it. So basically there's nothing new in that. But I would take about a year or so before we would get anywhere near success. And by success I mean conception and a successful pregnancy. And it was considered okay. They would say, fine, if a person is infertile, has had so many IVF failures, and even if it takes 1 or 2 years, great, you've done a great job. I said, yes, but I'm not getting the support from there. Now, to be very frank, I've been following my data. When Dr. Mahesh builds up the patient and then gives it to me, that's why I said the 5 petals, and then it's presented to me with those beautiful petals. I think, Mahesh, you will have to explain to them again what the 5 petals are, but I think we are quite used to that. You're referring to your system as a 5-petal system. It's a fantastic analogy. So I just found, to my surprise, 3 months and they conceive. A patient 1 month and they conceive. And I myself am surprised, and I'm sort of wondering that even if I were to present them, the first thing they'll think is this fellow is faking the data. How can it be 1 month, 2 months? But honestly, we have seen that. So I'm in fact hesitant to publish it, because unnecessarily there'll be too many questions raised. So once you have enough of these numbers, we will. But it tells me, yes, what the fundamental principle of BHRT also, focus on the nutrition, focus on the lifestyle, and then the supplementation of hormones. In fact, even for medicines, we have been taught in medical college, people tend to think that, quote unquote, allopathic medicine does not talk about nutrition, does not talk about lifestyle. Believe me, we talk about it. We get short notes in our exams, and in one breath we say improvement of lifestyle, full stop, and our job ends here. We tell a person, you improve your lifestyle. Now people like Mahesh or Sepalika and others will actually come concretely and hold hand and say, show how to improve the lifestyle. So this has created, and now I'm knocking wood, I'm touching wood, because I hope this is just not a beginner's luck sort of thing. I won't call myself beginner, but my association with Mahesh being just for a couple of years. So that I'm quite sure. So therefore, if today a patient comes to me, I would say, first, why don't you go through Mahesh's system, and I will do what it is. If it's for fertility, if it's for thyroid management and others, fine. I'm quite capable of giving you whatever you do best.
And I think I think this experience is mutual, doctor. There have been times when when we go by the completely lifestyle and food-based route, and it takes us a good 2 years to get somebody to a fertility stage. And there we have found that if we have done the build-up work for 3-4 months, and if we are able to take your support for the bioidentical hormones, then in a few months again we are able to get them into that fertility zone.
I understand. That's why I said when Tenzing, they could have gone to the base and they could have said, okay, we've reached here. But that to reach the peak, you need finally to make that extra step and put the flag in, right? Then it is complete. So I understand that you do everything. I mean, I could say you're my Edmund Hillary and I'm your Tenzing, because you do all that and then give me the last bit of the flag to do it. Anyway, you can sort of and I just seeing the comment here that says the 5 C's are important: corroborative, complementary, correct, complete, care with scientific basis will give the best outcome of treatment. And I'm so excited because we are living this. Believe me, this is every doctor's dream, that I can actually collaborate and do what's there, and I don't have to worry about my EMIs, my admissions, and this and that. But not everybody can do it because it takes time, effort, and basically conviction. Conviction is very important. I'll just give a very quick example why it's so important in infertility. If you can help a woman become fertile, that means fertility is not only for having babies or for conceiving. It means that nature wants you to be in the best of health. So you have achieved what's the best potential of health in that lady. So that means that if you were to continue it also, it would still mean that you're on the right track because you have maintained that. And how do I give an analogy for this? I'm using my car up and down. Suddenly I have to make a long road trip. Okay, which means that, okay, now I have to go for infertility. I don't say, okay, let's do it. I say, no, let me now check. Let me give it for servicing. Let me get my brake fluids, all that checked up, because I'm going to go on a long trip. And let me optimize everything, my engine, my alignment, everything, because I'm going on a long trip. I even want to document. So when going in for a pregnancy, should be prepared. You should not, accidental pregnancies, of sure, you can do unplanned pregnancies, that's fine. But most of the time when you're planning it, do not just plan to get pregnant. Say that, how do I prepare my body for a car? If I'm taking so much of care, if I have to go to Ladakh Leh and take my car, I take so much of care. Why don't I prepare my body and maintain it of that? And after the pregnancy outcome, when I come back, it's not over yet. I still have to get back to a good functional stage. I have to send my car back to the service, get everything fixed. Maybe some things happen during the journey, and therefore the same thing that you apply to a car when you're going on a long journey, apply it to your planning of pregnancy, and then you will realize what Mahesh does. His 5 petals and my 6th petal would be
like
the most logical way to approach.
Yeah. So maybe I should quickly explain to anybody who may not be familiar. 5 petals at Sepalika is basically the 5 arms of the natural treatment that we do. It's diet, it's dietary supplements, it's acupressure, it's Ayurvedic home remedies, and it's lifestyle changes. So we make sure that we build the foundation on all of these 5 aspects of life. And we always tell our patients, doctor, that, nature has only 2 dictums. There's preservation and procreation. If there's something wrong with procreation or, conceiving a child, look at preservation. The first question is about bioidentical hormones. And this comes from somebody who believes, why not take phytoestrogens or other hormones from plants rather than do BHRT? Because BHRT is not labeled as being free from side effects. What's your take, Doc?
All right. So firstly, it might come as a surprise to most of you that most of these hormones are coming from plants. Okay, you can't get when you eat them, you have to rub them. You see, this is very strange. Nature is providing you the answers and you are looking the other way. Whatever may be the reason, I can go into many reasons. But the question is, why would a plant like, what is the soya or, I'm forgetting the name, yam, why would they produce testosterone identical to human testosterone? I mean, why would that plant do that? What is it going to gain from that? There could be evolutionary thing on that. So the plant, nature is providing you this natural testosterone or bioidentical testosterone. All we are doing is, let's say in the ancient days, they would take the plants, they would use oils, they would use solvents, and they would massage it on their body. So if you think back, they were not just massaging for fun. They would not take any leaf. They would not take banyan ka leaf or people ka leaf. They would say that, no, you have to pick up this plant and that has to be, maybe ground in a particular way. So, and why oils and why this thing? Because that has to go through the skin, because they knew that hormones transdermal is the best way to get it. They also had systems of using the colon, the submucosa, mucosa. They have all systems. Some of the things you have to chew and spit it out. You don't swallow it. So remember, there's nothing new in what we do, but you should think that plants had a reason. Similarly, the estrogens, progesterones, They come from natural sources. The moment we take this, do you know that they talk about natural, all that? Do you know ethinyl estradiol, which is supposed to be the supplement, ethinyl estradiol, but the trade name was Primarin. Primarin. It was from the pregnant mare's urine. That's how it got its name. Pregnant mare's urine. Now you can say, oh, this is natural, but it is natural for the horse. If you're going to use, it's not natural for me. I can use pig's thyroid and say, oh, this is natural because the pig is natural. But there you have to be careful. See, you have to not get blinded and put your blinkers on and try to interpret things that go in your favor. You should say that is natural for the horse. This is natural for the pig. And if I take these, is it really going to do me good? Yes, it will also work because after all, that's also estrogen. So similarly, when you look at phytoestrogens or any other source of estrogen nature, I'm not saying they're bad. I'm saying that unless you have knowledge and you can tell the good from the bad, okay? In general, most of them are not natural with you. Okay, yeah. I'm using the word natural, quote unquote. But I suppose if you know which one of these phytoestrogens are good, and you mastered that maybe through your knowledge or through your experimentation, there's nothing wrong in using phytoestrogens or any form of estrogen that is there in nature. I'm not denying that. Question is, I don't know. I'm not a qualified person in that. But I know the next best thing is to take whatever is natural and say, this is working, bioidentical, I'm doing the blood test. After 5 years, you ask me, I'll say, look, now I have progressed. I can get into even better management. So I'm not outright saying that phytoestrogens are good or bad, but there's a problem that I'm saying. I'm saying that if you ignore the fact that those kind of estrogens are coming into your body and they are not being detected by our tests where we are testing for only estradiol and all, it may well happen that you would have created estrogen dominance and therefore you would have an issue if you're not in tune with that. Now, can you test for all this? Not necessary. You'll go mad if you start testing for all this. The question is, be aware, be aware clinically.
We use phytoestrogens, doctor. You're absolutely right. So we use the natural phytoestrogens at Sepalika, for example. Everything you can use literally seeds, like flax seeds are a beautiful source of phytoestrogens. So when you get into herbals, which are phytoestrogens, my only request to all of the herbal producers is, somewhere we have to accept that there should be a measurable way of seeing what impact this is having, right? So either clinically or in terms of blood work, we must be sure of what we are doing with our patients. And like Dr. Kadambi mentioned, most of the bioidentical hormones are being sourced from the plant and they are being refined in such a way that they present no threat to human being or don't have any side effects. So that's the main thing. We've got a question from a lady who's a patient herself.
I'll just qualify this. Let me not make statements like there is no side effect. Okay, my question is anything that has an effect, there can be a side effect. So it has to be supervised. But I'm using the word relatively. Okay, because I don't want to be into a thing that's saying that, oh, there are no side effects, and then immediately say, look at this, he's a quack. What do you mean no side effects? Yes, I can tell you extreme cases of side effects also of a natural product where you did not use it correctly. Sure, I'm not saying that, but it is important to realize that unsupervised anything can have a side effect, but supervised, and when you understand, because I'm seeing some interesting questions and I hope they really come. It's very important to understand that if I look at the other way around, should I take a negative what is called as informed consent? I can tell you one thing: if you don't take your estrogens and you don't replace this, if we are talking about menopause, I can tell you definitely what are the conditions you'll get. You get osteoporosis, you'll get cardiac disease, you'll get dementia, you may get Alzheimer's, you get many of these. Okay. I'm telling you what definitely you can get by not taking it. By taking it, again, I can't tell you will not get those conditions and these cancers, but you can reduce your risks, number one. Number two, you feel better, your lifestyle will be better. And if there are some side effects, of course, sometimes we have to change the medicine, you change the dose, we have to change the approach. I can give you enough examples when you discuss academically that I myself realized, okay, this is not working, I have to change it. So like anything else, you should not...
And I think it's important to sort of bring this discussion back on the fertility track. But before we do, let me also just underline what Dr. Kadambi said. Hormones fall under something called Schedule X of the Drugs and Cosmetics Act. They're not even in Schedule H. So the difference is this, folks. Schedule H is all those drugs that require prescription. So if, for example, antibiotics, your chemist is not meant to sell them to you without a prescription. Schedule X is those medicines which have to be under the active supervision of a doctor, not just prescription, but you need active supervision. And that is what Dr. Kadambi does. That is the supervision that is required for hormones. And when it's done properly, bioidentical hormones certainly have, we've used them with so many of our patients, and we know that used properly, you can minimize the side effects, not have any side effects, etc. And again, guys, don't go by the blanket term of side effects. If you drink, like instead of 1 liter of water, 2 liters of water, if you drink 100 liters of water in a day, you will die the next morning from the side effect. So even water, which is the most benign, can have the most severe of side effects of death if it's not used properly.
Yeah, speaking of, and since you have to be aware of time because I don't want to go on, but speaking of water, this is another example I gave a bioidentical. Okay, imagine that water is H2O. Okay, it's a molecule. You like to drink H2O. Now you say oxygen is good. So how about I make it better by adding another molecule of oxygen and make it H2O2, hydrogen peroxide. And they say, look, this is improved water. Please drink it. Now you see that one molecule, which is supposed to be a good molecule, can kill you. All right, or at least make you feel very sick. So the question over here is, once you understand that part, and because you mentioned water, I went back to my bioidentical which I give. Yeah. I'll come back to this. Let's come back to the topic.
Thin uterine lining with a possible infection, doctor. And she's saying, can you give me some advice?
All right. So I think slightly we are taking disjoint things, and therefore it's important to understand that taken together they have a different meaning, and endometrial lining thickness when it applies to a menopause. But I'm presuming that this is with respect to fertility. So if we are talking about,
since she's mentioning tubal blocks, this is fertility, and she's talking about a thin endometrial lining, which may be hampering her ability to fall pregnant.
Yeah. So let's take the simpler one. That like you have a problem, pani nahi aa raha hai, plumber says usme block hai, let me clear the block. So that's a simpler one. So you go there, there's a tubal block. Now, either you go see, sometimes that's one thing about when people start saying allopathy is not good and Ayurvedic is good and all. Some places, remember, surgery in allopathy can do wonders. So if surgically you can, and believe me, it's not always perfect because whatever you do in surgery, there'll be some fibrosis and all. But if you can open up that block, which is not easy, and there is a way of doing this, open up the block. Okay. But let's say that I don't believe the success rate of that is very high. If there is a block for fibrosis or whatever reason, unless there are some bands outside which you're separating, most of the time you can't get the physiological block change. Anatomically, you may clear the block. So be prepared that it could be disappointing, but you should go for the surgery for that. Second, if not, then the other option is to, of course, go for assisted pregnancy, where the ovum, you harvest the egg. You can do IUI, you can do IVF, whatever you would like to do, and go into that. When you have a block and the block is not giving way, do not try to keep on trying to go into all kinds of alternative treatment which will say that you can still conceive. Maybe you can, it depends on how much the block is, but be very clear. Either the diagnosis of the block is very clear. So that's the block part. Now comes the lining of the endometrium. The lining of the endometrium, it depends on which phase of the menstrual cycle you have measured it. So if somebody says my lining is, how much she said, I don't remember.
No, she hasn't given a quantity, doctor, and she's just said
it's thin. She says it's thin. Okay, so maybe the gynecologist says it's thin. So it depends upon which phase you do. So let's say that immediately after menses, it's supposed to be a certain thickness. And remember, in menopause and perimenopause, we are worried about thickening of endometrium because there's estrogen dominance. Now here, if it means it's thick, that means there's the proliferation. There are various phases. So your endometrium is not just the physical thickness; it's not mature enough. It's not mature enough to have an egg, a fertilized egg, implanted at the right place. So you have to interpret that. When somebody tells you, a gynecologist tells you that the endometrium is thin, what they're trying to say is you don't have adequate endometrium. And what improves the endometrium, what increases the endometrium is actually the estrogen, the phase. The first phase of the cycle is the estradiol goes up, and there is a sort of a proliferation of the endometrium. So I don't know the context, but in that context, if it is in infertility context, it will start. But again, this is the important part. If the person comes at the age of 45 or 50, I'm wasting my time there. If a person with the same implant is 25, 30, and of course today it's all 30 plus people are having kids, so we are in a different world now. But my point is, Why is it thin? There's nothing that I'll just stimulate it. I won't give injections to make it thick. I will therefore start with the 5 petals. After Mahesh finishes the 5 petals, there you may have the thick endometrium, or then I look into my thyroid, the T3. Then I will see whether you need any other fine tuning of that, and then allow the endometrium to thicken on its own. But if there is a block or there's no ovulation happening, it will not thicken because the feedback mechanism is not there. The nature always works on a feedback mechanism. That once that starts, and that could be because of some hormonal issue.
So basically what happens is, we've got the endometrial thickness, which is actually contributed by estrogen, which is secreted by follicles in the ovary that are maturing. That's a separate problem. The tubal block means that even though you are having ovulation, the egg is unable to travel through the fallopian tube and actually be fertilized and come into the uterus. So like Dr. Kadambi said, if indeed the blocks, if there are tubes are blocked, then what we have helped other people do is, when there are structural abnormalities like this and they need to go for IVF, we make sure that we bring them in such good health that the quality of the egg becomes far better, increasing the success rates of the IVF. So yes, we can do things like seed cycling by giving you certain Ayurvedic herbs, etc., which we do as part of our foundational work, which will help improve the quality of the endometrium separately. You may still need an IVF, but you must have heard that IVF success rates are as low as 33%, that also after multiple rounds. All of those can be improved. Once we have done the foundational work, we can look into your thyroids and see if the thyroid also needs support. That's something that Dr. Kadambi will, sort of take a look at and be the expert on it. And then we've had cases like that where people have gone to conceive with IVF and also carry the baby to terms. Why do women often have miscarriages in the first trimester, like this thin endometrium or any other case? Yeah. Can you speak about the BHRT network?
So that's a very good point. So the thin endometrium will raise a red flag. It's not that I'll ignore it. It's not that you can't get pregnant, but it's more likely to be unsuccessful, and I'll explain why. But before I come into that, just remember, if one of the tubes are blocked, you're still okay. Remember that you have, that's why, again, nature always gives, spares. You have a second ovary, you have second ovulation. If for some bad luck, you're not having. The very fact that you have a thin endometrium, it probably tells me that probably both are blocked, or one ovary is not functioning and bad luck, the other is blocked. Anyway, that once I have the data on that, is very clear. I can tell you way forward. The point over here is that I'd like to advise a person correctly based on the data I have. I wouldn't like to tell everyone it's too complicated. Life is there. Why just go for IVF? Straight away go for IVF, and this is the shortcut today. That we are so busy, we can't do this, we can't plan it. So that no. Second, once you need the IVF, I'm coming to your question. Remember, to make an IVF successful also, we have to optimize the hormones. 5 petals plus 1, the 6 petals. And whether you conceive naturally or through IVF, the same set of rules apply. We have to make your body as efficient possible. Now you brought up a very important one. Why is it that these people, so if I see a case like this, I will think, okay, maybe she'll conceive, maybe it will successful IVF. And by the way, because it is thin, sometimes the implantation might happen in the wrong place. This is also important. The timing is so important that it may happen in the wrong place, and therefore that will not even survive. That will go off. That implantation of the egg will not be successful. So there itself it'll take place. But let's say it's successful. I know that this patient will need a very good, most likely 99% progesterones are not going to be enough. Progesterones are not going to be enough. Don't wait for threatened abortion or any signs to happen. Start moment you confirm, okay, we have signed, patient is pregnant. Start with sublingual progesterone. Start with natural progesterone. Here it's important. It has to be natural progesterone. No synthetic progesterone will help. And the natural progesterone has to be of the highest quality, preferably through the skin or through the under the tongue, because there is a lot of issues when some people ask, I saw sustain. What about sustain? What's wrong with sustain? Any oral progesterone is the second best thing. It's not bad, but it's not as good as getting it sublingual. You can get to the levels. So when I see a thin and such this thing, I would say that even if you're successful, it's it's not time for celebration, because you have still full 9 months to go. So preparing, as I said, you prepare for the long journey. You have to prepare your body for that entire 9 months, because you want those also to go unsuccessful. There's no point in you going 3-4 months or early and having a miscarriage or threatened abortion, bed rest, or even for that matter, diabetes, pregnancy induced hypertension, all those things difficult to treat during pregnancy, but we sometimes don't have time. But prevention is important. So on that one aspect of a thin, if you have been told that you have a thin strip of endometrium, I would say that perhaps I would not suggest you try and conceive till we fix that. You have to fix it, and we can. I just came to that. No, so the implantation itself. So you may conceive, the egg may be formed, but it just rolls down because endometrium is not receptive enough. So again, technically speaking, when I say BHRT, it applies for replacement therapy in perimenopause or menopause, right? But I have to extend it BHRT even to the thyroid replacement as a BHRT, okay? Because this is my definition, but if I go by the book, or if I'm giving an exam, or I'm teaching students or PG undergrad students, I can't use this term loosely. But in practice, I would say, why do I say is because though T3 and thyroid is a mainstay, you know, the most important hormone in the body, people don't realize the most important hormone that forms the foundation of everything. If somebody says that, you know, I do tapas for 1,000 years and, you know, I get, you know, Shiva is happy and says, I'll give you one boon, only one item that you can give to all your patients, and only one hormone you can give, I would choose vitamin D. Because vitamin D or vitamin D, you say vitamin, I say vitamin. Vitamin D is firstly a hormone. So moment somebody says, or pro-hormone at best. If someone they says that hormones are bad, I say, well, if hormones are bad, then you should not be taking vitamin D. You should not be taking your insulins because hormones are bad, as you say. So this is the very important part, that your foundation, vitamin D, the B12, the omega-3s, and whatever Mahesh does, I keep repeating this 5 petals because I find that you know, concept very, very amazing. It puts everything in a nutshell. That you build those, and maybe you don't even need any of even the thyroids you may not need. As Mahesh says, in many cases, only in those cases where he reaches a level and feels that he needs it. This is also important. I would not have the respect for someone like Mahesh if every case he says, chalo, isme bhi thyroid dolo, give thyroid to everybody, give thyroid to everybody. I would say, look, let's build it up. And if they conceive naturally, and then if I look at it and I see, do we need to optimize? But I'm not saying, I'm saying that maybe for the kind of cases that come to Mahesh or come to us, they are the ones that are already miscarriages, bad upset history, others, they don't come directly. So 9 times out of 10, they will need it. But our justification, our scientific thinking should not go away. Just because it is 9 times out of 10, we'll say, chalo, sabko de do, what does it matter? That is what I'm against it. Even if the one time, if it is not necessary and you've given it or you've caused harm, you should be aware of it. Now, whether you feel guilty about it or not is a different story. But as a doctor and practitioner, you should be aware about it, introspect and say, yeah, I did something wrong, and I think this is not correct. And then change your ways if you can. So here's the thing. Sometimes you get carried away by the word. Okay, I've seen one ad, and one ad would advertise synthetic technology ke saath we have created. And everybody says, wow, 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 synthetic technology. And I said, but most of the time we think synthetic is bad. And another person says, organic, it's not synthetic. And you say, wow, wow, wow. So what happens is that I'm confused. So don't go by the word, go by bioidentical. I don't care whether it is made in a lab or it is made by a plant, you're extracted, or even if you can get it from animal, you know, I'm saying. But don't get confused. Everything that is not necessary, all the things that are synthetic are bad, okay? And it's not necessary that everything that is natural is good. So good example is horse's urine, it's natural. Horse's urine, you take estrogen from horse's urine, it's bad. I mean, it's natural for the horse. So the difference between synthetic and natural is only a terminology. What would happen is in marketing terms, when somebody doesn't understand, they say, and they say, look, I want a natural treatment. They say, they don't take any of those medicines. Huh? They're all synthetic. You take this medicine. Because some synthetic medicines, okay, which are made synthetically in the labs, they're good. I mean, antibiotics, if you use in the right places, they are good. Now, whether it is synthetic or use a natural antibiotic is a different story. So in case of thyroid and some things which are initially natural, they figure out, for example, growth hormone, bioidentical growth hormone, human growth hormone, they can create in the lab by DNA recombinant technique and create a bioidentical growth hormone. So now just because you made it synthetic in a lab doesn't take away that now it's no longer growth hormone, it will have some other functions. No, if it is bioidentical and you have created that exactly identical, if you start changing the molecules and then say that this is same like growth hormone, there's a problem. Like Insulin.
hear you, doctor.
Insulin you create in the lab is fine, but you make it long-acting insulin. You make it lantus insulin, and then you expect that body will accept it, because no, body knows that T3 is I need. If you give me T4, okay, I can take it for some time, but I need T3. So don't give me, I'm asking you for cake and you're giving me stale bread. Give me, something which not just enough to fill
So I
my
think,
stomach. So remember,
doc, this is
words are important. Yeah,
this
words are
is a
important, but
subject
don't get carried
that I
away by the
think,
word.
yeah, it's a kind of rabbit hole that we can, get into, because there's so much nuance in this. Doc, why is it that when you're saying progesterone is such an important hormone, it's hardly measured or corrected for in this country, especially, in the first trimester in precious pregnancy? What's been your experience? You're called the progesterone man at several conferences
Yeah,
that you've
people laugh at me.
been.
Here comes the progesterone man, because I talk so much. See, remember, if something people were giving, there's no need to talk about it. When I know, for example, I never need to talk about estrogens and testosterone, because yeah, people are giving it. But the reason I keep on harping about progesterone is that I call it the sidekick. Progesterone is the one that does all the work. But a lot of the time they say women and estrogens. Estrogens get all the credit. Because why? Because estrogen makes your skin smooth, makes you look beautiful, whatever. It gives you all those positive things. And progesterone gives you all the healthy things and protects from insulin. It's called the sidekick. In fact, whenever there is estrogen dominance, you increase progesterone, because progesterones can control it. So that's one part. But why do I say this is? This is more than just the fact that it's the sidekick of estrogen. The point is, sometimes you can't explain why, but it's staring you in the face. That's something which are very obvious. For example, somebody says, I got diabetes. Okay, I think I have diabetes. I say, which is the hormone? Most people, insulin. Insulin and diabetes, people know the connection. And then I say, why do you keep checking blood sugar levels? Isn't it good sometimes to check insulin levels? They say, no doctor checks insulin levels and all that. But for the life of me, I don't understand. I can understand that for thyroid problems, you check thyroid levels. For if you feel that the person has got menopausal issues, you check for estrogen, you check for progesterone levels. So similarly, we check, Mahesh and me, we will always check insulin levels. I'm not saying that the interpretation is different, but it's important to know that sometimes an obvious thing is missed. People don't check obvious things because they get so used to checking something for so many years, and they think that blood sugar equals diabetes. If I have high blood sugar, I have diabetes. If I have normal blood sugar, don't have. And we know that that's completely wrong. One. So when it comes to the progesterone, I believe there's a problem, because if you look at the normal range, if you test the progesterone and looking for normal range, almost everybody will be in the normal range. I can tell you the normal range in pregnancy. If I was reading one of the labs, it said from 2, and I don't know how they got the 2. Let me say from 12 to 150. I said, what a big range, And secondly, each trimester has an important range. So I think one of the major reasons why they don't check is that, one, it takes a lot of effort. Two, the patient will come to you and tell you, look, last time my progesterone is here, how to explain? It takes a lot of time. And three, if you don't have a compounding pharmacy or access to bioidentical hormones, right, what are you going to do? You can't use medroxyprogesterone acetate. At the most, you can use Sustain. You can use Sustain, which doesn't really serve the purpose. In any case, most gynecologists say, okay, if there's threatened abortion or there's something. But one thing I've seen a trend now, that gynecologists have started giving prophylactic progesterones without checking levels, but they have started giving it. It's a trend, which is a positive trend. But that's about it, some 200 milligrams or whatever, fix those, sabko de do, and that's fine. So at least that awareness has come that we have to give a little bit more than what the body produces. So I think that is a good sign. Now we are taking it to the next level. We are taking it to the level ki not just normal, let's take it to optimal levels. Why? Because we want the child and the mother to be optimally healthy. Okay, I'm not satisfied with what they say. It was a pregnancy, went through threatened abortion, got there, we prolonged it 36 weeks, then child was born premature, all that. If it happens, it happens. But if you plan these hormonal issues, you remember the word progesterone. I always say progestational hormone. It is a progestational hormone. It is the most important hormone during pregnancy. So if your body knows I don't have enough progesterone, believe me, it will not conceive, because the body knows no point in me conceiving, because I can't support, will not be able to support the pregnancy. And don't think that the body doesn't know. Give more credit to your body. Every cell is like a brain. Every cell has intelligence. Your gut is like a brain. So don't think that I'm trying to give some kind of sci-fi science fiction sort of thing that the body knows. When I say the body knows is that the chemical feedbacks of the body knows that this is not, we are not yet prepared for it, and takes a call. Similarly, when there is a miscarriage or in the early stages, the body is not is not happy doing it. Obviously, it's not happy doing it, but it knows that we can't sustain. I'm taking this car. I'm going to Ladakh Leh, but I have got not enough gas. My oil is not enough. I don't have enough power. So इसको यहीं पे खत्म करते हैं. Let not attempt to go there. So the body also will plan accordingly. And one way of the body to take it is, you can't control all the factors. You can't control, somebody has got a uterus which has got fibrosis, adenomyosis. You can't control that, but at least you can control the progesterone level. And the beauty of progesterone level is, nobody has ever today said that this level is the maximum or this is toxic. There's never been any level. Nobody even knows does progesterone have. At the most, at high levels, you will have water retention. Okay, you may have, and which is there in pregnancy anyway. So not just because of the hormones, for other reasons also. So I would say that you have such a safe option if it is natural. The moment you talk, you say dufasone, or you start talking dufasone, or you start talking about medroxyprogesterone, I said stop. Now you can't use that. That is not what the body wants. There is no deficiency of medroxyprogesterone. So once you have that clarity, you will know that I think that we should be able to prevent a large number of unnecessary miscarriages, unnecessary failed IVF. I'm sure we can prevent it, but we have to pick it early. My point is, it can increase, it can decrease. Measure the level. Okay, this is important. Progesterone levels are quite accurate. So if somebody brings me the lab level of progesterone, so remember, all tests are not bad and all. I can almost swear by a progesterone level unless it's really bizarre or the lab is bad. Most people, you can get an accurate reason. A progesterone can be accurate, but estradiol, be careful interpreting blood levels, because there could be many other different types. So therefore, you can use progesterone as a very good marker during pregnancy, but don't think you can do it for all hormones. To some extent, you can do for thyroid, but not as straightforward as progesterone. And never try to interpret estradiol based on blood levels. You will go completely wrong.
By all means, we will give you the guidance. Belle Santé Clinic is based in Bangalore. Fertility cases, we do work with Dr. Kadambi. Other cases, Dr. Kadambi works by himself. So you can find, we'll put in the description or in the comments, we'll give you the link to the Belle Santé website as well. You can get further guidance. I know that the kind of work that we're doing, because we are clear about the foundation building and the use and the proper supervision, legality, the quality, we're ensuring all of those aspects. So, thank you so much for doing what you do. And thank you so much for your time.
And thank you for making me your sixth petal. In fact, if you look at the Belle Santé logo, there is a green petal that is coming. So our logos are also, I'm also holding a petal. Okay.
Fantastic. Fantastic. Thanks everybody for joining. Big thanks to Dr. Vivek Kadambi, of course. Please do continue to follow Sepalika Fertility. If you have any questions, we'll be happy to answer. Thank you so much. Have a wonderful evening or day basis where you are. Thanks everybody. Bye-bye.
Thank you very much. It's not Sepalika Fertility, it's Sepalika happiness and joy. Amount of happiness and joy you brought to people, Mahesh. I mean, that's amazing. And I know how much you've done that.
Thank you so much, Doctor. And we're on this journey together. Thanks everybody. Bye-bye.